What's up, guys? This is Mike. I'm the Director of Communications for Overdose. Super excited to welcome you back to the Overdose podcast. Today, we're in conversation with Associate Professor and Addiction Studies Program Coordinator, Dr. Stephanie Rose. Dr. Rose brought naloxone in a first throughout the state of Arkansas to the University of Central Arkansas campus. She's advocated for similar initiatives statewide, and her advocacy is crucial to safer, healthier, and more well-informed collegiate communities. Throughout this conversation, we cover everything from the personal experiences that led her to addiction studies all the way to her groundbreaking work today. So tune in for the podcast. Hope you enjoy. See you next time. Dr. Rose, welcome to the Overdose podcast. So stoked to have you here.
I'm so thankful to be here.
Absolutely. And for those who may not know about you and your work, if you wouldn't mind just giving a quick introduction, telling us about yourself.
Sure. So I am an associate professor and program director for the UCA Addiction Studies program, and I also oversee the Master of Science Pathway to Prevention program. I always say I'm a social worker first. And so in all that I do, that social work, those values and the underpinning is grounded in a lot of what I do. And so that means a lot to me.
Absolutely. Yeah, you do so much amazing work in Arkansas. We're always so happy to be working with you. I would love to kind of start from the beginning. I know that, in your background, being surrounded by substance use in the family, struggling with substance use yourself in your early 20s, how did those things kind of inform and shape your worldview? And how did they eventually inspire you to pursue a career in addiction studies?
Growing up, my dad, I knew he was in recovery when he met my mom, and he had about 12 years of sobriety. He worked through tech school and became a paramedic. And I'll never forget, like, the rest of his family were heavy drinkers. My family was always like, you don't go tell people your problems. Mental health meds were looked down upon. The way you cope with stress is you come home and you have a few beers or a whiskey. That was kind of normalized in my family. I'll never forget the day my dad came home from a shift and he looked at my mom and he said, I don't know if I can do this anymore. And she was like, well, panicked, of course, right? 6 kids, how are we going to keep food on the table? How are we going to keep a roof over? Mind you, we weren't rich anyways. We were, barely making it. And he said, I just can't see any more dead families. He wanted to get into something else, but he also knew that would be hard to continue to support a family. So we started drinking after shifts, and that just graduated to full-blown alcoholism. So I saw all those changes in my dad. He lost his job because he was found to be drinking on the job. I didn't understand at the time, oh, he's experiencing vicarious trauma from being a first responder, which many of them do. Well, he died at the age of 51 from alcoholism. And I always tell everybody, opioids, meth, yes, very awful and dangerous, but please don't forget that alcohol is the third leading cause of preventable death in our country. So I went to a doctor and was like, I need some help. I've been drinking, and I know it's not good for me. She prescribed me some very addictive medicine, and I was only 18 at the time. So I really didn't know better. I found myself building tolerance to these meds. I was working a night shift, and then I got to where I couldn't sleep. So then I started mixing these meds with alcohol, and just had a wake-up call from some bad things that happened. And I was like, Stephanie, you're going down the same road. It's just the more of a legal way. And I knew I had dependency, and I was learning more about that while I was going through college. And when I went back to the doctor and told her what I was experiencing, she kind of blew me off, and she still wanted to prescribe it. And it made me angry because I felt like I wasn't heard, and I felt like she was more of an enabler. And I went to another doctor for a second opinion, and she was like, I am so thankful that you want off this stuff. I'm here to help you, wean you off. And I went through a withdrawal process that made me very empathetic for people who go through withdrawal. I was originally a nursing major, because that's what my parents encouraged me to do. I'm a first gen college student. I did all my prereqs for that. I worked in the hospital for 5 years. I went through 1 year of the nursing program, but it was just always in the back of my mind. I want to do social work. I feel like I can make more of an impact doing social work. But at the time, the stereotype with social work, all I would hear is there's too much job competition, burnout rates, people, you're just going to be taking babies away. And so, you know what? Someone has to do that hard work. But that is not just what social work is. That was another stigma. So I'm working in the hospital and I'm finding that I love talking to people, connecting them with resources, helping, family get through difficult things when they lost a loved one. And I just made my mind up. Do I want to be doing something that makes me miserable? Or do I want to go for a path that I'm passionate about? And once I did that, I never looked back and I got my BSW, my MSW, my doctoral degree. I never thought that I honestly didn't think I would work in substance use and misuse. I thought it was too close to home and that I probably wouldn't do well. I found out really quickly if you think that and you are a licensed, behavioral provider of any kind, you're going to deal with it. It hits everybody. And I started learning that I could turn my pain into a passion and I could help people. And people were clicking with that. And it just kind of started happening. And so I started educating myself more, getting continuing ed in that. I pursued my advanced alcohol and drug counselor certification, saying, I know they're like, can you come be our juvenile drug court therapist? And I said, sure, who's doing it now? And they were like, oh, our probation officers. And the kids just aren't talking. And I said, of course they're not talking. I wouldn't tell my probation officer stuff either. And so got into that and really learned a lot of what was working, what wasn't working, models that work. I did, after about 5 years, step away, and that's what brought me into higher ed because some kids that I had worked with since they were 13 in juvenile drug court or through various programs, some were ending up dead due to gang affiliations that they're trying to get away from and different things. And I said, I need a break. I worked with that kid from 13 to 18, and we're human and we need to know when we need a break. So I kind of passed that torch on and got into higher ed. And I thought, let's train more people. We have a shortage in this workforce. Let's have somebody come in and train. And I started at UA Little Rock School of Social Work. They had zero addiction programming. And I said, can we take one of these redundant policy courses and make it a required course? And they were like, sure, write it, propose it, see if curriculum picks it up. It is now a required course through their program. And then I got offered the addiction studies job, and I just was like, why would I not do that?
That's amazing, the journey you've been on. And would you mind explaining, kind of your work in addiction studies and what that looks like?
Yeah, so I think that being a therapist, a therapist and a professor is empowering to pay it forward, right? So, we don't only teach in our program. Teaching is very important, but mentorship is very important. Connecting our students to meaningful internships. And I love that we have an online program because I have students now who are certified all over the state, and we have so many rural areas that need it. And so, if I can empower a student to be able to remain in their community after they finish their degree, to me, that is giving back to the community and then they're able to pay it forward. So, we have, of course, our coursework. We also share our research. I've assisted other schools and programs to write their grants so they can get naloxone on campus, so they can get a peer support specialist because they don't have resources on their campuses like we're able to. We go down and mentor events for smaller colleges, like prevention festivals, awareness festivals, helping people get naloxone on their campus. We also work with all of the shelters in our community. And so our interns go into the shelters and they provide smart recovery groups, individualized services, a lot of things that these residents would not get otherwise due to not having insurance, being court mandated for certain things. And we were just seeing the shelter leaders are seeing better outcomes from our smart recovery groups versus some of the outside NA and AA groups where they were meeting with some nefarious folks at times when they're so new in their recovery. And that's real difficult when you have somebody offering, stuff when you're in the middle of trying to maintain your recovery. The last 3 years, we've done the Attorney General's Youth Summit. That's always a great thing. We like to give prizes out, get them involved. So they come up on stage and we'll have guess the press pill. And that's always a really big wake up call for young people because who knows? Sometimes they get them right, sometimes they don't. But really explaining that 7 out of 10 pills on the street right now, guys, are laced. That's, wow, never knew that. And so I do think that students, and I say this because I've heard them say it, I used to take Adderalls to help me cram for tests. I don't buy those anymore off the street. I'm like, I am so proud of you because there are healthier ways, to study and cope. And so I think what we do with our program is multifaceted and partnerships are important.
Yeah, absolutely. And like the combination between research and studies and real world application, like you're talking about, I think is really important. I know you've previously talked about that kind of combination between real world experience and compassion. How do you kind of bring that to the addiction studies program?
I am proud to say that about half of our students are people in recovery themselves. And I think that's wonderful. And then about half are non-traditional students. Having them in the class together, they teach each other a lot, but we start with the biopsychosocial model. So we're going to we want to get away from that it's a moral choice mentality, and especially with fentanyl that's different. People who think they're just and I'm not condoning marijuana use, especially before your brain is developed. However, I do think there's a big difference between marijuana and fentanyl. And so things that people did in their teens can kill someone today. And I don't think people make that connection. I don't think they think about, when I talk about marijuana being laced, I'm like, that doesn't happen. And I know my plug. And I said, so did my cousin, and when I tell that story, they're like, oh, that's a real life example of laced marijuana with fentanyl. So we start with that biopsychosocial model. We talk about ACEs. Arkansas is so high with adverse childhood experiences and trauma. That is the most common underlying condition when someone's struggling with substance abuse. We talk about the receptors in our brains and how some people are just more prone to become addicted because of that oversensitive dopamine receptor. I'm thankful that opioids make me sick and spinny and, I don't crave them. But my experience differs from one person to another. Same thing with stimulants. Some people really like stimulants, some people can't handle them. And so when we look at that brain science, that is very powerful. And then when we look at how these people grew up, what was normalized in their home, they were never taught any other coping skills but substances. And so we have to almost reteach that. We also cover behavioral addictions because we see people switching addictions, just to still get that dopamine shot. We're seeing a huge uptick in online gaming and gambling now, and it overlaps with substance abuse. So teaching from that perspective, and I always have them do a reflective exercise at the end and seeing that they get it, and it helped them to be more empathetic than they thought they already were is powerful. And I'm like, do not forget to pay that knowledge forward because there's still so much stigma out there that people don't understand. So most of what we teach is motivational interviewing and CBT, and we use smart recovery as what we teach for groups because it's evidence based. It works with all kinds of addiction, and we don't badmouth other groups, But the most important thing is that you individualize treatment, no cookie cutter treatment, because that does not yield good outcomes. And so by the end, our students better know how to write an individualized treatment plan with a client involved. It's not something you write. You've got to have your client on board with that for best outcomes.
Yeah, you just mentioned a ton of great points. One thing I think is reframing addiction away from a moral failing that I
Yes.
think causes a lot of stigma around it. And you kind of touched on this, but I'm just curious, would you say addiction is kind of a mix between nature and nurture? Because you know,
100%.
because some people might point to the environment, others might point towards genetic disposition. But would you say it's kind of a combination of all sorts of
I
things?
would. I would say I wouldn't have used alcohol as a coping skill if it weren't normalized in my house. My dad was of the mind of, well, if you guys are going to drink, I want you to drink here. And my dad is not alone in this. I hear this from parents all the time. Well, I'd rather them do it here where I can watch them and be safe. I'm like, no, normalizing that you are actually increasing your child's chances of lifelong addiction because you have normalized it in the home and normalizing it, it's a pathway. People, I haven't heard marijuana as a gateway drug in a while because I think we know people generally try alcohol or nicotine before anything else as early as 9 and 11, when we look at that. And alcohol is tricky. It's one of those substances that it can bind to every receptor. It's not just going to go after the dopamine like opioids do. It's not just going to, go after, what the stimulants would do. It'll bind to all of them. That is why it's so highly addictive. And also, we see a lot of graduation to other substances with that.
Yeah, and I don't think because of how normalized alcohol is, I don't think people understand that even like alcohol withdrawal is one of the most dangerous withdrawal processes you can go through.
Alcohol and benzo withdrawal can be fatal without medical detox. And a lot
Yes.
of people don't know that. And I would say that's the number one answer I get, even talking to clients, is I'm just afraid of that withdrawal. It's awful. And I know it's awful. I haven't withdrawn from opioids, but things I did get addicted to, it was like having a horrible flu. And so helping people get support, good evidence-based support, I think is very important. And also addressing and looking for and assessing for co-occurring mental health disorders is very important. Because I was diagnosed with PTSD from how I grew up and things I saw. I probably just should have been on, some kind of SSRI or something. Maybe start with that. Maybe not jump to Ambiens and benzos and different things like that, especially with young people who still have a developing brain. I was just thankful that I was able to kind of pull myself out of that with help, but recognize it. I've lost a brother-in-law at 35. He was keeping his alcoholism a secret. He went through 3 jobs, and we get a call one day that he fell and his liver was done. He had gone to a doctor, didn't report the drinking. He was retaining a lot of fluid. No, I don't drink alcohol, just socially. Well, they gave him diuretics, and when you mix diuretics and alcohol together, it ruins your liver. And so I really encourage people, when I have clients that come in and they're like, I'm really afraid to tell my doctor this. And I'm like, well, you have to tell them so they know how to treat you because there are things that you mix with alcohol or other substances. I mean, an opioid and a Benadryl could be all it takes to suppress your CNS enough. So I'm big on empowering. I'm trying to get away from that. I hear, oh, but doctors don't like therapists or counselors to talk to clients about medications. And I said, I don't subscribe to that. That's one reason we got into this mess. We are the number one opioid prescribing state. And I was harping on it when we were number two, let's decrease this. And here we are moving to number one. And so I encourage people, that is your time. You are paying that doctor. It's your time to ask questions, and it's okay to ask if this is addictive or if I need to look for dependency signs. And I'm like, write it all down before you go in there so you don't get that white coat syndrome. I get it sometimes. They get you in there and they rush you out, right? And you're like, I forgot to even ask what I wanted to. And so I'm really big on educating that yes, it is okay to ask your doctor, and we should be asking those questions.
Yeah, you brought up a point that I wanted to cover, that being Arkansas being the number one opioid dispenser. When I think of like the opioid crisis, like West Virginia kind of comes to mind, like the Appalachian region. So I was really surprised to learn that it's now Arkansas that's number one. What kind of comes into play to reach that number?
A lot of people are getting addicted from their own providers, but Arkansas, we're a blue collar state, so we honestly, and big on farming, a lot of work related injuries start this. We also have poor health literacy. We need to do a better job of educating people to empower them to make good decisions. I know we like to put a lot on providers. I think we need to do more education. Another problem is, and I experienced this myself, I injured my neck about 20 years ago working with kids, and I did a cartwheel, teaching them how to do a cartwheel. You can't do that when you haven't done that in a couple, like for a decade, but I was just learning that. And I just remember I heard a crunch and I couldn't move my neck. I didn't have health insurance at the time because I was just fresh out of school. And that was during that time. You either got it through your employer or you didn't, or you had a waiting period. So I've dealt with it all this time with trying to do it on my own. And I finally went and got an MRI. Almost my entire C-spine is out. And of course, they want to do surgery. And guess what they were pushing? Opioids. And I said, oh no, I've dealt with it this long. I'm going to keep dealing with it. There's plenty of alternative therapies, but it took me a year and the president of my university helping me to advocate for that. And I just think your average person probably wouldn't know to ask for that. I was like, I'll do the Botox shots down the neck. I'll do an epidural. Like, there's so many other things that we could try before going to opioids. But I've heard so many doctors say that insurance right now is playing doctor, and it's the only way to manage some people's pain because they can't get their insurance to pay for other therapies. I mean, I feel like I'm a pretty seasoned social worker and have helped clients work through these problems. And it was still difficult for me. And it's still expensive with copays. And so we're also a poor state. And so I think sometimes people are choosing what they can afford so that they can live without pain.
Yeah, and in terms of barriers, I know Arkansas being a rural state also creates another barrier of entry to having access to resources.
Yep.
I'm curious how you overcome not only maybe this predisposition to wanting to prescribe opioids, but then also having to overcome the hurdle of not even having resources to deal with opioids, if that makes sense.
Yeah, no, you're totally right. Because I'm thinking like when you say that and I think about the rural areas, most of your treatment for this is in central Arkansas in Little Rock. And there's people that can't travel and afford to travel for this. So we've had some good luck with telehealth. I'm currently on an STI SUD task force because the rates of syphilis, HCV are so high right now. They're treatable, but people don't know it and they don't know to get, tested. And so one thing we're working with, I'm very proud that Arkansas has this, is the River Valley Medical Wellness. They call it the Armor Unit. And our Attorney General has purchased several. One thing about Arkansas is our recovery and addiction family. We're like family. We're close. And we just know each other to help get people into beds, right, when they need it. And for those rural areas, we are working with those mobile units to get out there and provide that treatment. We are also working with engaging Arkansas communities. They also will travel to rural areas and do free testing for people. And while they're there, here's also resources for opioid treatment or whatever treatment you're needing. I've worked a lot with the Arkansas Opioid Recovery Partnership, and one of their big things is giving funding so we can have some beds in these rural areas so people have somewhere to go, and networks of transportation. Sometimes we'll just see a message, this person is ready for treatment, but they don't have transportation. And you would not believe the people who hop on that and help those folks. That is really a lot of the grassroots when you're dealing with rural areas. That those grassroots efforts are powerful.
Absolutely. And you brought up the sense of community when it comes to recovery throughout the state. You're obviously a member of the Arkansas Collegiate Network, which
Mhm.
does amazing work for recovery. I'd love to hear you just talk about your contributions to that and why you think it's so important that campuses throughout the state are all connected together in service to recovery.
Yeah, so and ACN or Arkansas Collegiate Network has went through kind of a revamp because I remember I would be like the lone professor as Dr. Rose and whatever student she could fit in her vehicle or they could follow me to the Capitol, and it was mostly just a press event really to bring awareness. And so I would usually have a speech. My students would speak from the student perspective. What we've had like three or four directors, and I'm just like, Dr. Rose is still going to be here. I really like to try to work with anybody who's doing this very needed hard work. But we had some directors who saw a different vision. It was like, why don't we meet on Zoom with all the state colleges and universities instead of spending a lot of money on a press conference in front of the Capitol? We can dole this money out and help different campuses put on meaningful prevention and education events. And so that looks like candlelight vigils for those we've lost to overdose, mocktails. Mocktails are fun. You don't have to have alcohol to have fun. And our nutrition club loves coming out and making those. So that's to me peers supporting peers. We have students share their stories. We have our own on campus drug take back day. So students can bring their meds they're not using and not just leaving them in the dorm. We really try to have a lot of events where belonging and inclusiveness is key. And just doing that, I've had clients break down and say, I've been needing to talk. I lost my parents to overdose, and I've been needing to talk about this. Something just clicked there. And so we give hugs, and then we're like, come see us over at we have a collegiate recovery coordinator. I got a grant from AORP so that we have someone who is just dedicated to prevention and substance use disorder treatment for our campus. And so those meetings are huge because we share ideas, we share support. If someone wants any of us from UCA to come out and help put on an event for their first time, if we can do it, we're going to be there.
Yeah, I think whether it's dealing with generalized substance use disorder, opioid use disorder specifically, the importance of community is so paramount to recovery, especially for young people. I got sober in college. I have almost 10 years sober, and
Congrats.
thank you. And showing up to a community where I saw other young people also doing the deal was hugely impactful and is what kind of kickstarted
Right?
me.
And there's another stigma. Oh, everybody does it. Everybody's doing this.
Yep.
No, not everybody is. It feels like that. And I can see how it feels like that. So I think it's important to have these alternative events on campus for students who don't want to necessarily go to parties and, possibly get into trouble or get into something that they weren't expecting. But that belonging and inclusiveness and decreasing isolation is just must be done for someone to feel safe to ask for help.
Absolutely. And speaking of campuses, you also brought naloxone to the UCA campus.
Yes.
which was a groundbreaking initiative. I would love to hear you talk about that, what inspired that initially, and what results you've seen since bringing naloxone to campus.
So I'm just a big nerd. I feel like if you're going to get a doctorate in a field, you've really just got to embrace the nerding out, right? So I'm watching all the data. And I'm like, oh, look at the West Coast, look at the East Coast. The trend is hits the West, hits the East, then it comes to Middle America. And it may look a lot different because we're not, like I said, that health literacy. We also kind of get like, oh, we're in Arkansas. That stuff doesn't happen here. Yeah, it does. I had that data, and I did have a little bit of pushback from one partner on campus, and I just was like, I just can't let this go. I need to talk with my president of the university. And he thankfully trusted me as the expert and said, well, if you think we need to do this, let's do this, Dr. Rose. And I met Tanisha Barnes, who was formerly, she was working with Arkansas Department Human Services and is now deputy director for AORP. And they came out to a documentary that I worked on with a student. She's an honors student and was a film student, but she was very passionate. She took addiction studies as her minor. And she said, Dr. Rose, I think I need to do a documentary on how trauma intersects with substance use. And I said, I think that would be phenomenal. Let me get you some folks to interview. And I invited the several stakeholders to that because I think that's important to see what she's doing. If they wanted to use that video, we're happy to share that. And I just was a squeaky wheel. I was like, I just want naloxone on campus and I don't know how to get it. And they heard me and they were like, what? We've been trying to find a university willing to do this. And I said, well, you found it. We held a press conference. We started off, I think, with 48 Nalox boxes. We did have several saves with those. Then we started really vamping up our prevention training. Every freshman that comes in gets that training. If I get invited to do a training in a class, I'm going to go. Then we started training our students to be able to do it, and it just grew. And now we have this wonderful end overdose chapter that will be starting on campus. And so now it won't just be Dr. Rose doing the trainings or my other colleagues, it will be peers training other peers. And I think that's going to be very powerful for Greek life, athletics, groups that don't want faculty in their business. And I get that. I try not to use scare tactics or shaming or anything. And I think that is such an important part of something I want to say here is that moral model. The reason it fails so much is guilt and shame are two primary emotions that fuel addiction and fuel relapse. If we can tell people and help them connect to their strengths and that motivation that I know you feel like you can't get on the other side right now, but I promise you can. And I'm here to, kind of stay with you and help them, like in smart recovery, we call them lapses. They had a lapse, but you know what? We can learn from it. One thing I learned is to tell my clients when we're in therapy is if you relapse, that's very likely to happen. What I don't want you to do is be too afraid to come back and talk to me about it because that's how we can learn. We know the average person, especially with opioids, about 5 times the relapses before they get that long-term recovery. And so I think we need to consider that when we're taking care of folks. And we also need to help give them some hope. That motivational interviewing to help get them ready for that change and to make those changes. And then that CBT to start challenging those. I can't make it without a substance. I can't do this. To what do you have within you that can help you get through this moment?
Absolutely. And you also obviously brought up End Overdose coming to campus, which I'm super excited about. I know Sierra is too. So, and you kind of mentioned it by saying that, maybe Greek life and athletes want to hear from other students. But I guess kind of big picture, why was it so important to help bring a nonprofit like End Overdose to campus?
I was reading about End Overdose. We had a mobilized recovery festival on our campus, and End Overdose was heavily involved in that. And what I had done was I was like, I really think I want to bring this to campus. I'm not that familiar with them. So I kind of did a mock chapter where it was more faculty led, and I was working with our health science club members to do it. And when I got to see the materials that you guys use, the training videos that you use, I was like, this is so developmentally appropriate for high school and college students. And so I got to see that in action. I got to see my students teaching other students. And so I was like, I think with these great experiences, why would we not bring this to campus? So I just love the formatting, the activities, that students can get online with End Overdose and do. And we still have folks who don't want to come to the trainings or ask for naloxone. So it's wonderful that they have an alternative option to get on End Overdose and take your brief training, and they'll mail you naloxone if you pay for the shipping. It just helps to get it out more. And that's what we need, because the opioids aren't slowing down. Every time we think we get something slowed down, someone creates something new. The more troops, boots on the ground, the better, in my opinion.
Definitely. And I know we've covered a ton of ground, and I guess one of my last questions for you is, from an overarching perspective, what would you like to see in the overdose prevention, response, and recovery landscape in Arkansas in the coming months and years?
Number one, we have got to get into the schools. The schools don't want to let us in to do prevention training because I think they think it looks like we're going to come and talk about fentanyl and opioids and, to kindergartners through fifth graders. That can just look like when you're feeling heavy or you're feeling down, what's a good coping skill? I know I was never taught good, healthy coping skills when I was growing up. I was told a lot, you need to suck it up. That's kind of a mentality that still exists. Don't whine, suck it up. All that taught us to do is hold our traumas in, not talk about things. And then we're acting from our fight, flight, freeze, or appease, right? And so, we see people going to prison. We see people getting hurt, getting in dangerous situations. I really, truly feel like we need to do a better job of helping people to coexist in healthy ways with unpleasant emotions and situations, because they're going to happen. We need to get away from, well, here, take this pill for that pain, because it removes it for a couple hours. That is usually what people are trying to escape, is what's in their mind and hearts, what they're feeling. They just don't know how to deal. So I think we need to do a better job of prevention education. We need to empower people to feel safe, to ask doctors questions, to ask for alternative therapies whenever possible. Naloxone is great, but the stronger these synthetic opioids that are coming down the pike, I'm afraid we're not going to be able to naloxone our way out of it. So prevention is huge, letting people know what's out there. And we know people are going to party. They're going to party anyway. Not everybody, but we are going to have those groups, right? I know harm reduction has become a dirty word for certain things, but if we can increase safety and resources, why not? And so that could even look like drink covers, test strips, different things that I give to students when they're telling me, if I go to this place, my drink gets spiked. Well, let's get you a drink cover and let's go talk to the owners as a group, and then I'm teaching my students how to advocate for themselves and within their own community. So a lot of that, we also have a shortage in this workspace. So it's very important to me to continue to graduate people who specialize in this and truly understand it, make sure that they're getting employed where then we have the greatest need. And so increasing that workforce, and then knocking down barriers for people who want to get certified in this. With our program, if you're a student, you get free supervision for those next 2 years to get your certification to test for your ADAC. And that I brought community partners and like peer supports who want to pursue their ADAX and even their addiction studies degree. And it's such a cool mix of learning. Everybody learns because I've got master's level, bachelor's level, and then peer supports in there. So coming together, talking, having events, um, awareness, it's multifaceted, is the short answer. And it's going to take more than one person. It's going to take a lot of us coming together.
Definitely. Well, it's because of the work of people like you that's really contributing to bettering this environment. So I really appreciate all the work you do.
And
Oh,
likewise with End Overdose, thank you so much for everything you guys are doing.
of course. Well, I guess my final question for you is there anything you want to add, anything you're working on right now that maybe people might like to hear about?
We released two needs assessments. Well, they were needs assessments, and then we also created how to's. Like, this is best practice. It's important to me that I publish in an open access journal because it's easier to give that information out. I've worked with some veterans. We are the 22. They're a group of veterans who seek to decrease veteran suicide and substance use. I highly encourage you to check that out. I can send you links to that. It's totally free, but it kind of talks about those veterans who get lost in the cracks of the system and how their frustration with not being able to get the help they need, the mental health services, and how it just kind of it's a catalyst for substance use, and then we're seeing really high rates of suicide. And as I mentioned, I went to the Synchronicity conference in DC. Highly encourage people to attend that. It's a lot of crossover of substance abuse and STIs that we're seeing growing. We have so many babies being born with congenital syphilis, and there's just no need for that when we can test and provide treatment. So that coming out, and I'm also finally, after a couple years of collecting data, I've got about 2,500 student responses on how they're feeling about these naloxone trainings. And that's another reason I think End Overdose is so powerful, because I'm looking at the research and the students still don't feel super confident. And I think that smaller group that you guys do, and you have the mannequin and people can practice, I think and hope that that's going to help increase our students' confidence levels if there is an overdose. We will have publications coming out about that, probably going to give End Overdose a shout in some of those, just to provide people with knowledge of alternative prevention education, treatment modalities, and resources.
Amazing. But yeah, we'll definitely be sure to include those links in the description for anyone watching or listening. But yeah, Dr. Rose, thank you again for joining the podcast. It was such a great conversation.
Well, thank you for having me anytime, and thank you, End Overdose.